regarding the principle of root canal preparations with the emphasis on the shaping part. The topic of root canal preparation is very lengthy and detailed. In the market, we have lots of the system of rotary files, and because it's very profitable for the company to produce this file. So when we look at the literature and all researches done today, we can see that the reason of the pulp and critical disease is the bacteria. So the successful endodontic treatments is the elimination of the bacteria, intercanal or extracanal bacteria from the root canal system by following the biological, chemomechanical, and microbiological principles. So the chemomechanical preparation, which is including the mechanical instrumentation and antibacterial irrigations, eliminate the bacteria from the root canal system. So this is one of the critical stage of canal disinfection. So the good root canal shape is necessary for the effective irrigations and final root canal obturation. Because of that, we said that the root canal preparation or cleaning and shaping is a master skill in endodontics. Because excessive shaping causes problems. Less shaping even cause the same problems. We have a sentence that says the 5 shapes at irrigation cleans. Its main point is just for shaping. Of course, they are even using for cleaning of the canal, but the main thing for cleaning is the irrigation. But irrigation and instrumentation it should be both together. So, what are the goals of mechanical root canal preparations or root canal shaping? Is to remove the most of the vital and necrotic tissue from root canal system. Create sufficient space for irrigation and medication like intracanal calcium hydroxide. Preserve the integrity and location of apical anatomy and avoid iatrogenic damages like perforation, ledge, and etc. And facilitate the canal obturation and conserve the sound and the root sound and to maintain functional tooth, as the document said regarding the crack. So ideal canal shape is based on the conventional way of irrigation that we use in the clinic, apart from the using gentle wave or laser. Regarding what we use as the irrigation in our clinic, the ideal canal shape is continuously tapering conical form of the canal to achieve the well canal clean, well packed obturation, and conserving the maximal tooth structure. So when we are talking about engine driver rotary instrumentation, it consists of 2 things. One is the file, one is the motor. The handpiece, endodontic handpiece in endodontics can be categorized in 3. One is the full clockwise rotary handpiece, which is most common form of the handpiece. This is the full rotary instrumentation handpiece, which is more common in the market. But nowadays, another type of motion, which is watch winding or reciprocating, like the wave one or the stroke, is becoming more popular among the general dentists. So what are the benefits of rotary instrumentation? So it's obvious that there's operator's comfort, less finger pressure and fatigue, and less instrumentation time, creating less canal transportation, ledge, and perforation, providing the better center and rounder preparation, creating the taper canal, as I mentioned, less extrusion debris, which is very important in clinical setting because it causes less flare-ups after. Overview or the 9-type. The 9-type comes from the development of like Vogler and Wang in early 1960s, and it produced the nitinol, the alloy which is super elastic alloy. And we have different types of nitinol nowadays, the 55, 60, or others, based on the amount of the nickel inside. What are the characteristics of the nitinol or nickel titanium alloy? Is low elastic modulus is one force to 1/5 of the stainless steel. So it's caused the file very flexible. So excellent flexibility or little resistance to pressure and shape memory alloy, which is in the primary generation. So why this crystalline of nickel titanium alloy is flexible? It's because it has in two main phases and it can transform. So in the rest situation, it has in the phase of the austenite, and under the temperature reduction and the stress, it goes to the martensite. So this, in fact, transformation from austenite phase to the martensite phase, it caused the pseudo elasticity. It means the flexibility and ability to return to the original shape. But we should know that this kind of deformation is for the nickel titanium alloy is just 10% straight can be recovered compared to the stainless steel, which is just 1%. So this is the file in the phase of austenite, which the crystalline phase is very stable and rigid. Under the cooling or stress, it goes to the martensite phase, which is somehow can be reversed. And but if the pressure and loading increase, it goes to deform martensite, and with the heating, it comes back to the austenite phase. But what are the disadvantages of nine-tie rotary files? The most and more important thing is the nine-tie file doesn't show any sign of fatigue before fracture. And also they have the poor resistance to the fracture compared to the stainless. They are expensive, difficult to manufacture and manage. Some of them, they have shape memory, right? Especially in higher sizes and paper, they can cause the transportation, ledge, and perforation. So this is the wrong sentences. Some said that the nitride doesn't produce a ledge or transport. Yes, they can produce, but it's less than a stainless steel. And in ability to preserve the file, especially for circuits in the first generations. So we should know this is the misconception that super elasticity is not equivalent with the super strength. These files are not that much strength compared to the stainless steel. So the unpredictable fracture, then the canal blockage, and the poor cleaning and shaping, and it caused the failure. So two main categories for the factors influence the file fracture can be categorized to structural factors and operational factors. The structural factors is related to the files, is related to the manufacturers, the quality of file. But the second one, which is more important for us, is operational factors, like the torque and speed, apical pressure, manual bypass, and etc. We can go through that. So this principle I'm going to tell you is not applied for all the systems, but for most of the systems. Because each system has different, in fact, instructions. So the first principle is follow the manufacturer's instruction when you choose the file. It's very important to know that when we use the file, we have to use the file with high quality manufacturing of that, with less defect inside the file, or some surface treatments on the file. This is very important. The file design also is very important, but when the cross-section of the file is smaller, it's more flexible, and it gets less stress, less micro void, and less fatigue and fracture. The torque means the forces when act in rotational manner. So the torsional fracture is occurs when the torque limit is exceeded. The torque comes from both things. One is from the motor or handpiece, one is from our hand or pressure we use. So when the instrument, in fact, is rotating inside the canal, when some part of the file, or especially the tip of the file, binding the canal and engine rotating, the file is fractured. This is called torsional fracture. So using the torque control machine is highly recommended. We have different types of motors, some of them is wireless, some is smaller, some bigger, but all of them, they provide very low speed and high torque of the rotation for the rotary instruments. Because the rotary nitride file requires constant speed and torque to prevent a stress fracture. So even if you use the machine, you have to check from time to time whether the machine is working properly or not. Because one of the reasons of the fracture, especially when the machine is becoming old and couldn't produce the constant torque and speed. The anatomy of the canal is very important. In some cases with the sharp curves or sudden curvature or a shaped canal, and the canals that joins together should be avoided with kind of rotary instrumentation because of its fractures. Especially those cases like type 2 canals and then become one canal. Or this case is more difficult or difficult. When the canals join together, the file gets fractured very easily. So don't use inside this canal. Especially type 2 looks very easy cases, but there is a risk of the fracture. So this is the cases when we have the very severe curvatures. So in this case, shape memory files are not recommended because the file is fractured easily. So then we have to use hybrid instrumentation, the combination of rotary files and even the hand files. Irrespective of any system we use, these files are not designed for pathfinding, for negotiating our constricted or calcified canal, abrupt curve, and bypassing the ledge. Always use the irrigation and lubrication of the canal when we're using the rotary instrumentation. So this can be sodium hypochlorite, chelating agent, or any liquid inside the canal. So avoid using the file inside the dry canal. What is the light touch? Is the pressure applied for writing with the sharpness of this called the light touch. We have different manual motion by rotary files. One is the brushing motion, which rotary file is moved laterally to avoid threading inside the canal. This motion is effective, especially for a stiffer instrument with positive break angle and a stiffer instrument, like the Prototyper SX can be used in this motion. The motion I prefer and use it is pegging motion or up and down motion. It's just 1 or 2 millimeter up and down with a light touch to desired working length or when we met the resistance. Another motion is insertion and withdrawal. That's not that much common. This is the pegging motion. So you can see the file along the long axis, and passing filing motion and a slow progression to the exit, 1 or 2 millimeters. So the technique most of the system we use is crown down approach technique, and especially emphasizes on the pre-flaring of the coronal part of the canal, pre-flaring of the coronal part allow to more control in the apical preparation. Limit the number of use. That's very important, especially in high curvature and constricted canal. Limit apical pressure, and apply the manual bypass technique to reduce the contact between the file and the edge. What's the manual bypass? Always you know. It's the filing of the canal with the hand file, number 10 and 15, with light touch, before using rotary file. It can be done with some rotary instrumented like pathfinders, but again, I prefer the hand file because I would like to explore the canal to see any curvature or any obstruction. So it's very important to make a space for the rotary instrumentation and cause less fracture. Regarding the number of uses of file is long debate, but to be honest, the best is the single use of nitride rotary file. The single usage means sometimes use one time per case or sometimes one time per canal. In that cases with the severe case, I remember that I used 6 S1 because there is a risk of fracture. Thank you very much for your attention.
My name is Val. I'm a periodontist. I've been practicing for about 8 to 9 years in Toronto, together with our group. And this lecture is going to be focused on immediate implant treatment, so immediate implant placement and immediate provisionalization. So I'll show you some principles, how it works. I'm going to show you different kinds of cases, so different applications of this technique. So I'll be talking about site preparation, so the biomechanical principles to how we achieve sufficient stability for implant, for the provisional prosthesis, but also maintain the supporting bone. So we'll be talking about site preparation, how we undersize the osteotomy enough to get good primary stability. We'll be talking about bone density, how we measure bone density, how we prepare for each implant site, the insertion torque, the implant stability quotient, so basically alternative ways of measuring the stability, basically objective measurements, implant geometry, the designs of different implant systems, and the surface enhancements, the latest advancements there. So when it comes to undersizing the osteotomy, we're working with living tissue, right? So we have to work within the physiologic limits of that living tissue. So the bone must be kept in mind to prevent compression necrosis. So that's in the surgeon's mind all the time when we're planning the surgery. We want to have sufficient stability, but we want to get just enough to do immediate load, but we don't want to overcompress the bone. So that's a very, very fine line that we're sort of treading. And that's most of the thought going into these cases is getting just enough stability, but not over torquing. That's how it works with immediate implant placement. So if you have excessive undersizing, then you get reduced bone to implant contact, and you get actual micro cracks in the peri-implant bone. Besides measuring your insertion torque, you have the resonance frequency analysis, which is a bit of like it's a tool which you can measure. It runs like a resonance, like an electromagnet on the implant. You insert a peg and you measure it from 2 different angles, and it gives you like an objective measurement of the torque you got right when you place it. And then a few months later, you're checking for integration. You can take another measurement and compare, but really it's the insertion torque that's the most important. Implant surface enhancement. So there's been a whole bunch of different types of surface treatments for implants, and there was one called the hydroxyapatite surface, which was popular about 20 years ago. It had a very, very high implant, like bone to implant contact, up to 80%. But the problem with that hydroxyapatite surface is that after about 10 years, the surface actually came off the implant. So they stopped manufacturing those implants. And strongly carries this line. It's the sandblasted, large grit, acid etched surface, the SL active, which it attracts a uniform coating of a fibrin clot. So the moment the implant is placed, you get a uniform fibrin clot all around the surface of the implant, and that accelerates the formation of osteoblasts on the implant itself. So that surface is stable, it doesn't come off the implant, and it maintains bone to implant contact of up to 60%. So first case is a 40-year-old male. As you can see, he's got fractured upper front tooth. He's got quite some crowding of the upper and lower teeth. Has some mild periodontitis, so we're managing the gums, we're managing his front tooth, which is his chief concern. We're discussing his crowding as well, so we're managing all these things at the same time, but looking at the patient's priority. So his priority is he wants to manage the gum, but he also wants to replace his tooth, which is cracked and infected. So always when I'm planning the case, I have a discussion with the patient and with the referring dentist to let them know that we're going to address the patient's chief concern, but they have to be aware they have crowding. We're going to plan an implant. That's his chief concern, but that's going to limit the ability to straighten his teeth later on if he decides to do that. So the front tooth had a root fracture, had endodontic lesion. Next case is a patient also about 45, congenitally missing his central and lateral incisor. Referred to place a single implant at the central incisor site and be loaded with a cantilever crown. So that's the case. He also has generalized gingival recession, so I review with the patient where, yes, your priority is going to be replacing this missing tooth, but you also have gum recession. So I give them an idea of areas that can be improved, that can be addressed later on, and I do root coverage grafting, usually with connective tissue or with dermal matrix substitute graft. So in this case, you can see the bone is extremely narrow. It's almost a knife edge ridge. But we have a nice concavity here, which is great because you can build laterally off of the concavity. So that's the implant plan, the preoperative, and then I can get an idea for how much I want to build or how much I can predictably build laterally. So we go ahead. I plan to build up the bone first, same as before, titanium mesh lateral graft and some vertical graft as well. This patient wears an Essex and we have to wait a few months. So 6 months later, the graft has healed, it's fully calcified. You can see how much bone we got just in 6 months. That's preoperative and postoperative. The implant is simulated. So we enter the site again with, I remove the framework, I have a CAD/CAM guide.
What was the bone graft cut?
So the bone graft that I use, so many of my cases are anterior cases. As a perio, that's a lot of my referrals. And I use a mixture of allograft and xenograft, but usually about 3/4 allograft and 1/4 xenograft, because I seed the graft with some xenograft because it's very stable dimensionally, it never shrinks. So after a few years, it will maintain the volume. And I find that this titanium plate, which was sort of used a lot by Picos, Michael Picos, back in the day, he became famous for this technique. I was taught this technique in my residency in Vancouver. Definitely is technique sensitive, but when it works, you get amazing regeneration of the bone. Since then, there are the lasso technique, which is invented by a Brazilian periodontist, which doesn't require any titanium framework. It's you don't get as good of a result as a titanium plate, but basically there's less risk because you don't have a framework that can get exposed and things like that. Next case is 4-unit bridge for upper anterior. This is a 37-year-old female with having had orthodontic treatment in the past and severe root resorption and mobility of her upper front teeth. So you can see what's left of the 1-2 to 2-2. The 1-1 and 2-1 are class 3 mobility. The 1-2 and 2-2 are class 2 mobility. So in planning this case, the question is, do we plan implants at the 1-1 and 2-1 site and leave the 1-2 and 2-2 alone? Advantages, we can retain the 1-2 and 2-2. The disadvantage is that cosmetically, it just won't look as good as having a proper 4-unit bridge where you can maximize the emergence profile and make it look harmonious. So these are decisions we're making and discussing with the patient and the referring dentist. So you can see the bone that's left, and you can see how much bone is available for the implants. So, and again, in this patient's case, with the planning lab, we're correcting the occlusion, the teeth are splayed, we're bringing them back into alignment with the provisional bridge. We're trying as best as possible to come out with cingulum. So I remove the teeth, I have a CAD/CAM guide, I'm placing them to proper depth, and then I have my healing abutments, I'm checking the proper, checking for the emergence profile and to see how tall the temporary abutments have to be. I have my temporary bridge. I retrofit the bridge, the mill PMA bridge to the cylinders. I polish the transition between the abutment and the cylinder. I'm grafting, and I insert the bridge, and again, no sutures at all. So implants are placed, the bridge is inserted, no sutures, and that's immediately post-op. That's pre-operative, and that's immediate post-op. Pardon me?
How do you fix the titanium plate?
I use retaining tacks and retaining screws to keep it fixated in place.
Okay.
And I spent
in the buckle,
on the buckle and the palpable. So in this case, I would have used maybe.
Everywhere has a bone.
Pardon me?
Everywhere has a bone. You can use the tack.
Yeah, I try and use tacks first, and if they don't work, then I use screws, and I have
Can you
different
use
sizes.
that technique for mandibular when we don't have enough height to inferior or ulnar canal?
I use titanium plates, but I stay away from the mental foramen. So whenever I'm grafting, if it's a very advanced resorption and I have to use a titanium plate, I use it, but I always stay away from the mental foramen. I stay far, far away.
How about the diameter? Wow.
Oh, like a ridge split. Ridge
Yes.
split.
Yeah,
The ridge
ridge
split
split.
technique. Some of my colleagues are using the ridge split technique. Some of my colleagues out west. I'm just beginning to use that ridge split technique. I am more comfortable with the titanium mesh. But that is a valid technique. Ridge split technique is a valid technique.
Titanium make it more height and more diameter?
Yes.
Both?
Both. When you have proper flap reflection and you have freedom of the flap and you get primary closure without tension, titanium plate works really, really well. But it takes time because you have to fixate it properly. You have to make sure it's smooth. You have to get good flap closure. But yes, you get height and you get width with
And
titanium
do you
plate.
use membrane or collagen on the membrane?
Underneath, yeah, underneath and above. I sandwich multiple collagen membranes like a sandwich. So
Sorry.
Yeah.
At the end, when you are going to put your implants, you drill the mesh, you drill the titanium plate as well?
I remove the
You
plates.
remove it.
I always
You
remove the
it
plate
and
then place
okay.
the implants. So this is the case. Implants are placed. Then the patient was satisfied. He has teeth in the upper. Now he wants to begin the lower. The lower is more complicated. It's extremely a narrow bone. So here, originally we were planning independent implant bridge. That was the original plan, but the bone was extremely narrow. So this is a case where I did my best to rebuild the lateral bone with, again, titanium plates, and we got some degeneration of the width, but as the bone is healing, the anterior teeth that were remaining became more loose. So we have to switch gears into another plan that's going to work for the patient. His molars that he has left are solid teeth. They're periodontally sound. They're supporting his posterior BDO. So we're thinking about maybe a hybrid solution that will replace all of his front teeth but still maintain the posterior teeth. So this is an interesting case because I planned a hybrid, but a partial arch hybrid. So I planned 4 implants in the interforaminal bone, and then I plan to scallop the bone and protect the bone at the molar. So the patient keeps his last molars, and he has a hybrid for the rest of his teeth. So that's what we did. I placed 4 implants in the anterior. We loaded with the denturus, loaded with an immediate hybrid. So you can see 4 implants. We have a cantilever of only 1 molar on either side, and in this hybrid stage, there was no contact with the molar, so there was a gap. So there's no touch in the immediate hybrid. that's the case, we removed the hybrid 10 days later. Tissue is healing very well. You can see that you have good spread of the SRAs. They have nice soft tissue all around them. And I also plan to have convexity in the immediate hybrids. I plan for the surface to be convex, because when you have when you plan in the immediate hybrid a convex surface, you get a concavity in the actual soft tissue, and that leads to more stability of the supporting bone around the implants. I'm planning to begin to use the Sonident Aura 8 for my socket preservation. So it's interesting material that can be used after socket preservation to protect the supporting bones. So it's an interesting product, which is a non-usual protective dressing. So I'll begin to use this.
Do you stitch it or just tape?
This, from what I've been seeing and reading, it's stitched to give it some support in the beginning, so it doesn't move around. Thank you very much for your time.